I want you to stop for a second and ask yourself one honest question. When was the last time you truly finished? Not almost, not close, not it was fine. I mean a full, complete, deeply satisfying orgasm that left every single muscle in your body relaxed and every thought in your mind quiet. If you had to think about that for more than 2 seconds, this video is for you. Here is something that I tell every single woman who walks into my clinic feeling confused, frustrated, or quietly ashamed about this exact question. You are not the exception. You are not broken. You are not difficult. You are, statistically, scientifically, and clinically, the majority. Research published in the Archives of Sexual Behavior surveyed over 52,000 adults and found that while 95% of heterosexual men reported reaching orgasm regularly during partnered sex, only 65% of heterosexual women said the same. And when researchers dug deeper into why that gap exists, the answer was not anatomy. It was not desire. It was not chemistry. It was position. It was angle. It was the complete absence of information about what the female body actually needs to reach orgasm. Information that has existed in medical literature for decades, but somehow never makes it from the journal to the bedroom. Today, that changes. I am going to walk you through 5 scientifically validated, urologist-recommended sex positions for female orgasm. Not 5 positions someone made up. Not 5 things that look good on camera. 5 positions chosen specifically because of what they do to your anatomy, because of where they direct stimulation, what structures they activate, and why the female nervous system responds to them the way it does. Stay with me through this entire video, because position number 5, the one I'm saving for last, is the one that has genuinely changed the intimate lives of women I have worked with in my clinical practice. And it is the one that almost nobody is talking about. Let's get into it. Hello, and welcome back to the channel. I'm Dr. Lila Romano, intimacy counselor, marriage therapist, and sexual health specialist with over 15 years of clinical experience working with couples and individuals navigating some of the most personal, most vulnerable, and most important aspects of their health and their relationships. If you are new here, welcome. I want you to know right from the start that this is a completely safe, completely judgment-free space. I talk about the subjects that your regular doctor rushes past in a 10-minute appointment. I talk about the things you are too embarrassed to search online. I give you the real information, the science-backed, clinically grounded, clearly explained information that every adult deserves to have about their own body. If you have been here before, welcome back. Thank you for continuing to trust me with your time and your well-being. You already know what we do here. Before I give you the 5 positions, I need to give you the science first. And I know that sounds like I'm making you wait, but I promise you this is not filler. This is the foundation. Because once you understand what is actually happening inside your body during arousal and orgasm, the positions stop being tips you try once and forget. They become tools you understand completely and use with total confidence. So, let's start with the anatomy. The female orgasm is, at its most fundamental level, a neurological and vascular event. Your nervous system fires a very specific cascade of signals. Your blood flow increases dramatically to the pelvic region. Muscle tension builds throughout the body. And when that combination of nerve activation and vascular engorgement reaches a critical threshold, that is the orgasm. That is the moment of release. Now, there are several key anatomical structures involved in this process, and understanding each one is going to make everything I say about the positions make complete and immediate sense. Let me start here because most people, including, I have to say, many medical professionals, have a deeply incomplete understanding of what the clitoris actually is. When most people hear the word clitoris, they picture a small external nub. And yes, that external glans is part of it. It is the visible tip of a much larger internal structure. The full clitoral complex, as described in landmark anatomical research by Australian urologist Dr. Helen O'Connell, is a large wishbone-shaped organ that extends deep into the pelvic cavity. The complete structure includes the external glans, which is what you can see and touch, the clitoral shaft, which extends internally upward from the glans, 2 crura, which are long curved arms extending backward along the pelvic bone on either side, and 2 vestibular bulbs, which are internal erectile structures running along both sides of the vaginal canal. When a woman becomes sufficiently aroused, every single part of this structure fills with blood and engorges, just as a penis engorges during arousal. The entire complex swells, becomes dramatically more sensitive, and in doing so, actually wraps more closely around the vaginal canal. This is critical information because it means that the right internal stimulation, at the right angle, in the right location, can activate the internal portions of the clitoris even without any direct external contact. That is the anatomical basis for why some positions work and others simply do not. Here's the fact that I share with every patient who has ever felt like their body is not responding the way it should. The external clitoral glands, that small visible structure at the top of the vulva, contains more concentrated nerve endings than any other structure in the entire human body. The most recent anatomical research using advanced three-dimensional imaging suggests the number runs into the many thousands, significantly more than the entire penis. All of that in a structure smaller than your fingertip. What this means practically is this. That structure needs direct, sustained, rhythmic friction or pressure to generate the neurological cascade that produces orgasm. It is not difficult to stimulate. It is not mysterious. It simply requires the right approach, and most standard sexual positions, as we will discuss, do not provide that approach by default. The G-spot debate has confused people for decades. Some researchers have insisted it exists. Others have said it is a myth. Let me tell you exactly where the current science lands on this. The area known as the G-spot, located on the anterior or front wall of the vagina, approximately 2 to 3 inches inside, is not a separate anatomical structure. It does not have its own name in the anatomical record the way a bone or organ does. What the G-spot actually represents, according to current urological understanding, is the vaginal surface of the internal clitoral complex, specifically the area where the vestibular bulbs and internal clitoral roots sit just beneath the vaginal wall. When you stimulate the G-spot, you are stimulating the internal roots of the clitoris through the vaginal wall. This is why the controversy existed for so long. People were debating whether a structure existed when they were actually describing 2 different access points to the same anatomical network. And this also explains why simultaneous G-spot stimulation and external clitoral stimulation feels so dramatically more intense than either alone. You are engaging the same system from 2 directions at the same time. Before I move on, I need to say something that I consider clinically non-negotiable. Your anatomy is not static. It changes during arousal in ways that are physiologically significant. When you are fully and adequately aroused, not just physically touched, but mentally present and emotionally engaged, the vaginal canal elongates by up to 2 centimeters. The uterus and cervix lift in a process called tenting. Lubrication begins, and the entire clitoral complex engorges and shifts position slightly, bringing the internal structures into closer proximity with the vaginal walls. Every single position I am about to describe works significantly better. In some cases, only works correctly when you are fully aroused first. If you move into these positions without adequate arousal, you are essentially trying to engage anatomical structures that have not yet activated. Please do not skip foreplay. It is not optional. It is physiologically required. One more thing before we get into the positions. I want to name this clearly. That research I mentioned at the beginning, the 95% versus 65% orgasm rate between heterosexual men and women, that gap is not natural. It is not biological inevitability. Women's bodies are fully capable of consistent, reliable, powerful orgasms. The gap exists because of 3 specific things: a lack of accurate anatomical information, a cultural overemphasis on penetration as the only sexual act that counts, and a persistent silence around female pleasure in medical education and public health communication. Every position I am about to share with you is chosen specifically to address all 3 of those factors. Let's go. I am starting with missionary, and I want you to stay with me because I know exactly what you are thinking. Missionary, really. But hear me out, because the version of missionary I am about to describe is not the standard position you already know. It is a clinically studied modification that has been shown in published research to dramatically increase female orgasm rates. And it has a name. It is called the coital alignment technique, CAT for short. The CAT method was developed and formally studied by sex researcher Edward Eichel in the 1980s. And his work was published in the Journal of Sex and Marital Therapy. A follow-up study in the 1990s confirmed his findings. Women who used the CAT method reported significantly higher rates of orgasm during intercourse compared to women using standard missionary. The mechanism is elegant, and once you understand it, you will never think about this position the same way again. In standard missionary, the penetrating partner positions themselves directly above, and the primary movement is in and out. What this motion primarily provides is vaginal wall pressure, For the majority of women, remember, 80% cannot orgasm through penetration alone. This is simply insufficient. There is no consistent clitoral engagement happening. In the cat modification, the penetrating partner shifts their entire body upward by approximately 2 to 4 inches. Their chest moves higher. Their pelvis elevates relative to their usual position. Their weight is supported on their forearms rather than their hands. And the critical result of this shift is that instead of thrusting in and out, the movement becomes a forward and backward rock, a grinding motion, where the base of the penetrating partner's pelvis creates continuous, rhythmic friction directly against the external clitoris with every single movement. Think of it this way. Standard missionary is a hammering motion. The cat is a rocking chair motion. The bodies stay in continuous contact. The clitoris receives sustained direct stimulation on every forward rock. You are no longer relying on internal stimulation to somehow reach the clitoral roots. You are engaging the most nerve-dense structure in the human body directly and consistently. To make this work even more effectively, the receiving partner should place a firm pillow or a specially designed wedge pillow under the hips, tilting the pelvis slightly upward. This does two things simultaneously. It brings the external clitoris into even closer contact with the partner's pelvis on every movement, and it adjusts the internal angle so that penetration now presses more directly against the anterior vaginal wall, engaging the internal clitoral complex from the inside at the same time. The rhythm should be slow, deliberate, sustained. This is not a technique that rewards speed. The neurological buildup that leads to orgasm through clitoral stimulation requires consistent, uninterrupted pressure, not fast movement. Women who have learned this technique and given it the time it requires consistently report that it becomes one of the most reliably orgasmic approaches they have ever experienced. I will say one more thing about this position that I say to every couple I work with in therapy. This technique requires you to tell your partner what you need. Not a long conversation, just simple, clear guidance in the moment. Move up a little. Now rock instead of thrust. That is all. Your partner wants to give you pleasure. Let them know how. Position 2 is woman on top, and I want to spend real time on this one because of how many women are using this position in a way that is leaving enormous amounts of pleasure completely untapped. Research published in Hormones and Behavior and additional data from the Female Sexual Function Index consistently identifies woman on top as one of the positions most strongly associated with female orgasm. The reason is simple and powerful. When you are on top, you have complete control over angle, depth, speed, rhythm, and type of movement. You are the architect of your own experience. No other position gives you all of those variables simultaneously. But here is where I see the problem in clinical practice over and over again. Most women, when they get on top, bounce, up and down, in and out. It feels natural. It looks like what they have seen represented in media. And it is, for the majority of women, not the movement that leads to orgasm. Why? Because bouncing is primarily an in and out motion. It creates depth and vaginal wall pressure, but it does not consistently create friction against the external clitoris. And as we have now established clearly, the external clitoris is where the majority of the orgasm story happens for most women. The modification that changes everything is this. Instead of bouncing up and down, lean slightly forward and grind. When you shift your weight toward your partner's chest, not sitting straight upright, but leaning forward at roughly a 30 to 45 degree angle, your external clitoris moves into direct contact with your partner's pubic bone or the base of their body. Now when you move forward and backward rather than up and down. Your hips roll, your pelvis rocks, and every single forward movement creates direct sustained friction against your clitoris. You are in complete control of the pressure, complete control of the speed, complete control of the angle. This is your body. You are driving. Now here is something I spend time on with individual clients because it matters enormously. Every woman's anatomy is slightly different. The exact angle of lean that perfectly aligns your clitoris with your partner's body is unique to you. You will not find it immediately. You will find it by experimenting. Lean slightly forward, more forward, now a little back. Pay attention to when the sensation becomes most concentrated and intense. That is your angle. Remember it. Return to it every single time. I also want to give you the clinical tip that I consider one of the highest impact recommendations in this entire video. Using a small clitoral vibrator while in the woman on top position is one of the most consistently effective strategies for female orgasm in partnered sex. Research by Dr. Debbie Herbenick and colleagues, published in the Journal of Sex and Marital Therapy, found that adding vibrator stimulation to intercourse increased the likelihood of female orgasm dramatically, moving from the approximately 18% baseline baseline for penetration alone to well above 70% with combined stimulation. That is a transformative difference. A vibrator is not a replacement. It is a tool. Use it without shame. And finally, Woman on Top is psychologically powerful for a specific reason that goes beyond the physical mechanics. When you are on top, you are not passive. You are not waiting for something to happen to you. You are actively directing your own pleasure, listening to your own body, following your own sensations. For women who struggle with being present during sex, with staying in their body instead of drifting into their thoughts, this position gives the brain a clear, active task. It becomes significantly harder to spiral into self-consciousness when you are focused on driving your own experience. Position 3 is rear entry, and I want to talk about this one with the same clinical precision we have applied to the previous two, because the anatomical reason it works is genuinely fascinating. Remember the anterior vaginal wall, the G-spot region, the vaginal surface of the internal clitoral complex? In most face-to-face positions, the physics of penetration direct pressure primarily toward the posterior wall, the back wall of the vagina. This is simply the geometry of how bodies align in most positions. Rear entry reverses that geometry entirely. Because the penetrating partner approaches from behind, and typically from a slightly lower angle, and because the natural curve of an erect penis or the angle of a toy faces upward in this configuration, the anterior wall receives direct consistent pressure with essentially every movement. A 2010 paper in the International Journal of Impotence Research specifically identified rear entry as one of the positions most anatomically suited to anterior wall stimulation, noting that it engages the internal clitoral complex through the vaginal wall to a degree that is not easily replicated in face-to-face positions. But rear entry is not one position. It is a family of positions, and small variations create dramatically different experiences. The standard all-fours baseline is effective, but two modifications improve it significantly. The first modification is chest down, hips elevated. The receiving partner moves from hands and knees to resting their chest on the bed or a pillow while keeping their hips raised. This does two things. It increases the angle of penetration, so it targets the anterior wall even more directly, and it opens up the ability to consciously engage the pelvic floor muscles during the act, which we know from research significantly intensifies sensation and orgasm strength. The second modification is face down with a pillow under the hips. The receiving partner lies flat with a firm pillow elevating the pelvis and their legs together. Legs together naturally narrows the vaginal canal, which increases the intensity of sensation, and the anterior wall pressure in this configuration is maximized. There is one important clinical reality I need to name about rear entry. While it is exceptional for internal anterior wall stimulation, it does not typically provide direct external clitoral contact. The bodies are not aligned for that in this position. So to achieve orgasm here, you need to add clitoral stimulation, either by reaching underneath yourself with your own hand or a vibrator, or by having your partner reach around to provide manual stimulation. Either approach transforms this position from excellent internal stimulation to complete clitoral complex engagement. That is the combination that produces orgasm for most women. Position 4 is one that does not get nearly enough attention in conversations about female orgasm. And I think that is because it looks like a minor variation of missionary, but the anatomical effect it creates is genuinely significant and quite different from anything we have discussed so far. In this position, the receiving partner lies on their back as in standard missionary, but raises both legs, either resting them on the penetrating partner's shoulders, wrapping them around the partner's waist at a higher position than usual, or holding them up at roughly a 90-degree angle to the torso. The penetrating partner kneels or stands at the edge of the bed. The elevation of the legs does something very specific to the pelvic anatomy. When the legs come up and the hips tilt backward, the vaginal canal changes its axis. The cervix shifts. The angle of the vaginal canal rotates in a way that brings the anterior wall, again the G-spot region, into much more direct alignment with the angle of penetration. What was previously a glancing contact with the anterior wall becomes a direct targeted pressure on every movement. Simultaneously, this position naturally deepens penetration because the pelvic tilt removes the anatomical curve that limits depth in flat missionary. For some women, this deeper reach combined with the anterior wall angle creates a sensation of stimulation that feels qualitatively different from other positions, more internal, more diffuse, what some researchers and clinicians describe as a precursor to what is called a blended orgasm, involving both internal and external stimulation simultaneously. To add external clitoral stimulation in this position, which I always recommend, the receiving partner's hands are completely free and unobstructed. There is nothing preventing direct clitoral stimulation with your own hand or a vibrator throughout the entire act. And the penetrating partner's hands are also free in most configurations, allowing for additional stimulation of breasts, inner thighs, or anywhere else that contributes to your arousal. One clinical note on this position: the depth of penetration can be intense and for some women uncomfortable, particularly if the cervix is being contacted. If you experience discomfort, lower your legs slightly from the shoulder position to a hip wrap position, which reduces depth while largely preserving the beneficial anterior wall angle. Your comfort is non-negotiable. Adjust until it feels exactly right for your body. And here we are, position 5, the one I promised you at the very beginning of this video would surprise you. I want you to genuinely set aside every visual idea you have about what exciting or effective sex is supposed to look like. Because this position, the lateral scissors position, also called side-lying, is in my clinical and research-informed opinion the single most underrated position for female orgasm in existence. And the reason almost nobody talks about it is precisely because it does not look dramatic. It looks quiet, slow, almost too simple. But let me tell you what the science says, and then let me tell you what I have seen in my clinical practice, and I think you will understand why I saved this for last. In the lateral scissors position, both partners lie on their sides, either facing each other or with one partner behind the other. The bodies intertwine so that penetration occurs from the side, with the legs creating a natural scissors configuration. Movement is gentle, slow, rocking. The bodies remain in continuous, full-length contact throughout. There is no performance happening in this position. There is no athleticism required. There is just two bodies pressed together, moving slowly and deliberately in sustained intimate contact. And here is what that creates anatomically and neurologically. Because the bodies are pressed together in continuous full-length contact with the pelvises aligned, there is sustained consistent pressure against the external clitoris throughout the entire act without any specific technique required. The anatomy of the position produces clitoral contact naturally. Unlike the cat, where you have to learn the upward shift, or woman on top, where you have to find your forward lean angle. In the lateral position, the clitoral contact simply happens because of how the bodies are oriented. Beyond the mechanical advantage, this position has a psychological and neurological benefit that I consider equally important. The research from the Kinsey Institute and multiple other institutions studying female sexual function consistently finds that emotional intimacy, feelings of safety, connection, and being truly present with a partner is one of the strongest independent predictors of female orgasm. This correlation is significantly stronger for women than for men. The lateral position is the most emotionally intimate of all the positions we have discussed today. You can see your partner's face, you can speak, you can feel the full warmth of their body against yours. Kissing happens naturally, touch is reciprocal and unhurried. The entire nervous system signals safety and connection, and that signal, that feeling of being safe and present and completely seen, feeds directly into the neurological pathway that leads to orgasm. For women who struggle with spectatoring, the clinical term for the habit of mentally watching yourself during sex, monitoring your own responses and appearance, this position is uniquely therapeutic. There is no display happening. There is nothing to perform. You can close your eyes and simply feel. And because the position is physically gentle and low energy, it can be sustained for extended periods without fatigue. This matters enormously because sustained moderate stimulation with gradual arousal build is one of the most reliable pathways to what researchers describe as a full-body orgasm, the kind where the contractions extend beyond the pelvis and waves of sensation move through the entire body. That type of orgasm requires time and an unhurried arousal arc that this position is perfectly designed to support. There are two versions worth knowing. In the face-to-face version, both partners lie on their sides facing each other. The receiving partner lifts their top leg slightly, allowing penetration from the front. Movement is a gentle forward-back rock of both pelvises together. In the spooning version, the receiving partner lies with their back against the penetrating partner's chest. Penetration occurs from behind. The top leg can be draped over the partner's hip. In this version, the penetrating partner's hands are completely free for simultaneous clitoral stimulation, and the angle replicates some of the anterior wall pressure we discussed in rear entry, giving you internal stimulation, emotional warmth, and direct external access all at once. If I could make one single recommendation to a woman who has never experienced orgasm during partnered sex and wants to change that, I would tell her to start here. In this position, with adequate arousal first, with a partner she trusts, moving slowly, without a goal, just following sensation. Before I let you go, I need to talk about one more dimension of this, because if I gave you 5 positions and said goodbye, I would be leaving out the most important variable of all. Positions are powerful. The science behind them is real. The anatomical logic is sound. But the research is also crystal clear on this. The single strongest predictor of female orgasm is not position. It is mental and emotional state. There are 3 patterns I see in clinical practice that block orgasm more reliably than any wrong position ever could. The first is spectatoring, mentally watching yourself during sex instead of being inside the experience. Monitoring how you look, whether you're taking too long, whether your body appears a certain way. The antidote is sensory redirection. Every time your mind moves toward a thought, bring it gently back to a sensation. What do you feel right now? Warmth, pressure, movement, breath. Stay there. This is a skill and it develops with practice. The second is treating orgasm as the goal. When orgasm becomes the destination, every moment without it becomes a small failure, and that subtle pressure creates exactly the neurological tension that prevents orgasm from arriving. The research is consistent. Women who approach sex with a pleasure-focused rather than outcome-focused mindset report significantly higher orgasm rates. The less you chase it, the more readily it comes. The third is staying silent about what you need. If you know what helps you reach orgasm, a specific touch, a specific position, more time, a certain kind of emotional connection beforehand, and you are not communicating that to your partner, you are working alone. Your partner cannot read your mind. Tell them. Not apologetically, not as a complaint, as information, as an act of intimacy. Let's bring this home. Today you learned 5 science-backed positions proven by urological and sexual health research to maximize female orgasm. Position 1. Modified missionary with the coital alignment technique for direct sustained external clitoral friction using the rocking motion. Position 2. Woman on top with a forward grinding motion for complete personal control over angle, pressure, and clitoral contact. Position 3. Rear entry with anterior wall targeting for deep internal clitoral complex stimulation through the G-spot region. Position 4. Legs up missionary variation for anterior wall pressure combined with depth and full freedom for simultaneous clitoral stimulation. Position 5. The lateral scissors for natural sustained clitoral contact, deep emotional intimacy, and the unhurried arousal arc that leads to full body orgasm. And we talked about the mental work that no position can do for you, being present in your body, releasing the outcome, and using your voice with your partner. Here is what I need you to carry with you from this video more than anything else. Your body is not difficult. Your body is not a mystery. Your body is extraordinarily well designed for pleasure and connection and release. And it has been waiting not for something to be fixed, but for the right information, the right approach, and the right conditions to do exactly what it is built to do. You deserve that. Your pleasure is not a bonus feature of your intimate life. It is a fundamental part of your health, your confidence, and your connection with your partner. And today, I hope I gave you the knowledge and the confidence to go claim it. If this video gave you something real, please give it a like right now. That one small action helps this information reach the women who need it most. Subscribe if you are not already part of this community. I publish every week on sexual health, intimacy science, relationship wellness, and everything your regular doctor does not have time to tell you. And leave me a comment. Tell me which of these 5 positions you are most curious about. Tell me what topics you want me to cover next. This community grows when we talk to each other, and your comment might be exactly what another woman needs to read today. Coming up soon on this channel, why some women have never experienced orgasm, and exactly what changes that. The role of hormones in female sexual desire across different life stages, and how to have the intimacy conversation with your partner when communication has broken down. Stay with me. There is so much more to come. Until next time, take care of yourself, advocate for your own pleasure, and remember always, knowing your body is not vanity. It is health. It is power. It is yours. I am Dr. Lila Romano. I will see you in the next one.